first 1,000 subscribers will get essentially free set of doctor eyes on their report. Early supporters will get lifetime discount, and you can cancel at any time. Today I have founders of SangBio with me here. Let me pull up the website. And what they're trying to do is to change the medicine as we know it. If you read Peter Attia Outlive, that's probably as close as we get to Medicine 3.0, which is evidence-informed, deeply preventative, and highly personalized. So I'm going to introduce myself, and we'll get rolling, and then you, the viewers or listeners, are going to decide for yourself if that's medicine and extra life is something you want to participate in. So as I said, my name is Alex. I'm running all these social media channels, and I'm trying to convince people that dying is bad. And you would think it's an easy proposition, but it's not what we do usually in our daily life. Usually trade health for money or health for entertainment. And it's not what the government is doing on a big scale, just looking at how much money goes towards war. And it's not what my friends in Harvard Medical are doing, even when they get some money for aging biology. They only get such a minuscule slice out of it. So I was like, okay, what can I do? And I created a plan and started to just create awareness and connect people like you with other good people. So hopefully we can make something meaningful, at least in the next, hopefully 50 years. so we can see the results. It's sort of like a two-part plan. Let's support aging biology, and let's live long enough to actually see the results. And one of the pillars which you need to have is medicine. Current state of medicine, and at least in the States, is kind of horrible as far as preventive goes. If you want emergency service, then yeah, you'll be saved. But if you want to avoid heart disease, cancer, all this horsemen, it kind of sucks. So usually it's up to you to be proactive and do something about it. That's why I think what you do, in a way, you're trying to solve at least one part of this problem by creating more affordable medicine for everyone. And second part is make people use it. And that's hopefully where I could add some value. And maybe together we can, at least get something. So
That's amazing, yeah. Thanks for sharing that, and thanks for doing what you're doing. We need more people like yourself.
Yeah, because in a way, if you would have 1% of population just be on the same page as I am, we would solve aging in next 20 years. Well, maybe 50, but it would just change everything completely. So, well, in worst case scenario, we all get like extra 20 years just for trying. Because if you want to live longer, it has to be your priority. Yep. Otherwise, you get average. And if it's your priority, you're almost guaranteed to get extra 10, 20 years of healthy life. And not just dying slowly, but, compressive morbidity. Are you guys all in Singapore?
So Saif is in Canada, Nishant and I are in Singapore.
Okay, so it's actually the next day location, right?
Yeah.
I don't know, like, because to me it's still like you are in my future.
That's one way to put it. Yeah.
And I'm still amazed that technology can connect us from the different sides of the globe, and it's probably something my kids won't appreciate. But for me, it's still amazing and kind of tells you how much technology can improve our lives.
Yeah, it's crazy.
So, yeah, our medicine is what we have right now, as I said, sucks. And I think the only feasible solution is to have some artificial intelligence to assist the doctors. So your regular person have somebody to talk to longer than 15 minutes, which is allowed at least in the States by insurance. And and if you want personalized approach, forget about it. You probably need to be in the concierge service, which will cost you tens of thousands of dollars each year, and not necessarily will give you the good results, because practice, at least here, usually runs 20 years behind the science. It takes generation to get into the medical school, teach that to students, and they get it to the practice. So there is definitely a lot of things which technology can unlock for all of us. So tell me more. What's your vision? Why you do what you're doing?
So we previously built a primary care analytics platform. It's the largest one in Malaysia. It's basically an EMR plus analytics. So we built it ground up. And our goal back then, when we started it, was to pretty much unlock medical data so that we can improve patient outcomes. And the simple, analysis being that if you have trends, longitudinal data, then you can look at how to improve your outcomes for patients. And the idea was that with longitudinal data, we can improve patient outcomes. And what we saw was we were able to improve patient outcomes, but actually a lot of the impact that we had was more on the pharmaceutical companies. While it wasn't part of our vision, it showed us that the incentives for the reactive care systems are clearly aligned for certain stakeholder in that sense. And that's when we asked ourselves, what can we do to help really use data to improve patient outcomes? And we were very convinced that it wasn't possible in the reactive care system as we know it today, just because it's a very complex system with like insurance providers, wellness providers, doctors, patients, and no one has a direct relationship with each other. And it's an industry that's existed for such a long time. You can't change it. It's not something like Uber or something where it's a very straightforward relationship.
Yeah.
So we couldn't put a finger on it and say that it's going to be the health span, the longevity industry as we call it today. And it was only probably like 2-3 years ago when we personally started experimenting, we started to see this take shape. And then we put ourselves through many tests, all the consumer tests, name it, we did it. And that's when we realized that, most consumers will not have the luxury that we have in terms of understanding why you should do this test, when you should do this test, or even if you should do this test. And in terms of cost versus benefit, in terms of the science, because there's so many tests coming out, which one do you do? That's why we got started.
Yeah, which test will have the most actionable impact?
Yep.
So I was talking about DEXA scans. DEXA scans is the new way to measure your fat percentage, visceral fat percentage, etc. If you go to a hospital, ask for a DEXA scan, typically they'll do the bone density scan. Sure, that helps, but it's not useful for most people unless you already have a predisposition for bone disease. And even if you get the full scan, there are a lot of variation. For example, I got a DEXA scan where the visceral fat number was actually not shown. So what use is that DEXA scan? There are other metrics that are useful, like appendicular lean mass ratio, how much fat is in your upper body versus lower body. But you can know these numbers, but it's not enough to know these numbers. And you can also know, you're in the 5th percentile in terms of population or 90th percentile in terms of population. But you also need to know at which point is it a problem. Just because you are in the bottom 5th percent of the population in one specific measure doesn't mean anything. It doesn't necessarily mean it's bad. Your body might have adjusted to that kind of metric. It's not true of all metrics. For example, generally, it is now accepted that, for example, if you take a calcification score, if it's high, it is a problem, 100%, because it means you actually have plaque in your blood vessels.
Build up.
Exactly. So some cases it's clear, some cases it's not clear. So then it has to tie back into, for your context, let's assume you know your fat already. So then obviously the thing to do is reduce the fat, and an DEXA scan is not going to help tell you, oh yes, you're actually fat, but the scan is not going to give you any new information in this regard. So all this needs to be sifted through. And But there's a cost component. DEXA scans are not cheap in most countries. It can cost you $100 easily. And you want to understand the additional value each of these tests provide. There's also the situation where some people, if they have more information, you get more stressed because you're worried about it. Now that stress might be worth it if there's real risk. It may not be worth it if it's unclear and you need to wait and see how things evolve before you actually make any decision out of it. So in that sense, it's a complex web of forces at play, even if you're committed to the process of understanding more about yourself and maximizing your longevity.
Yeah, you always need to triangulate between different tests and patient and his history and everything.
Yeah. So with the idea, with an inkling of an idea, we started talking to people in our circle, in the longevity community in Singapore as well. And as we talked to more and more people, it became quite obvious that there was a class of people who were more than 30 years age and who were trying to be health conscious. They had some problems in their family history. They're concerned about aging a certain way. They might have personal goals that they want to achieve when they're 60, maybe run a marathon or carry their great grandchildren. But they really did not know where to get started. What they wanted to do was know which test to do, when, and why, in a way that it gives them an accurate assessment of how their health is going and what they can do to reach their goals.
Yes, it's ultimate prevention in a way, going from the lowest hanging fruit to higher, and then it depends how deep are your pockets and how much you're ready to commit.
Yeah,
as far as I understand, right?
Yeah, and I've seen this personally myself. I took my first comprehensive blood test at the start of the year, and my HbA1c didn't look good, right? My grandma had diabetes, my mom, my dad, all three of them have diabetes. I'm not pre-diabetic yet, but it's on the high range. The doctor saw it, and the doctor's like, whatever.
Yeah.
Like,
you didn't cross the thresh mark.
Yeah, and that just did not sit right to me. So yeah, we put our heads together and we came up with this idea of SangBio.
Mm-hmm. So did you get CGM for a week at least?
I did.
He did.
Yeah.
Okay.
Yeah, he got converted to a CGM user, and it helped him a lot, I believe.
It did.
Yeah, because it changes your mind more than anything else. Because you kind of knew already. Most people know where they kind of have lapses, but when it talks to you directly with tests, then it's kind of hard to ignore.
Yeah. So that's why we created SangBio. We met up with Professor Jan Gruber from NUS School of Medicine, and he had just published a paper on how you could use your standard biomarkers to predict disease-based mortality, and you didn't need to have complete set of results. Even if we had partial results, it was able to predict. Albeit less accurately, but there are very few models out there that can do this. And that's when we got thinking in terms of, okay, how do you use this from a real life application perspective?
Are you looking to like any Horvath clocks or anything like that? Grim Reaper?
Jan has built a clock of his own. It's a Modality clock. Yes, it's inspired by Horvath's clock. Horvath's clock is very old. I think it's 25 years old. So there are two kinds of clocks. One basically is an age predictor where you can have any metric, for example, the color of your eyes, and then you collect color of your eyes and age for a large number of people, and then you use the color of your eyes to predict your age. Now, this doesn't mean anything when it's color of your eyes, because the implication of you're older or younger isn't much. Those clocks are most of the clocks that you see. You step on a weighing scale, it tells you your age is X, or you go to the gym and they tell you age. They are all those kind of clocks where they try to do an age prediction. The other more interesting kind of clocks are risk clocks, which is what Horvath's clock is and which is what Jan's clock is as well. Risk clocks basically tell you, so there's a risk curve, right? So generally as you age, you are at higher risk of, say, mortality or a certain dysfunction or certain organ not functioning properly. And there is a curve that kind of reflects this. It doubles every 8 years, I believe. So you can basically, if you're 8 years older than your current age, that means your risk is twice of the people on average on your age. So that's the kind of clock that we are looking at, which actually gives you real information that if you're older, your risk is actually higher. So in this case, we basically take a large data set of people. There are biomarkers, things that you would measure on a blood test, a blood panel, and then you follow up and see what did they die of and what were the reasons that that happened, and how, I mean, basically how long did they live, and then you kind of try to predict how long you will live based on your biomarkers or which person do you most resemble, and that gives you a risk.
Yeah, it can be separate conversation because I do have a couple friends who are right now preparing work on clocks for Foresight Longevity Conference, and they're working on improving the Grim Reaper clock.
Okay.
It's my friends in Boston, because we do want some clocks to test the interventions without waiting for 50 years.
Exactly. Exactly. Without the clock, there's no way of knowing whether what you're doing is actually working or not. You have to wait for 50 years, as you said.
Yeah, and this is just one kind of clock that we're using in SangBio. There is another class of clocks which are more targeted for organs or diseases. Yeah, and we'll be using those as well to do more targeted risk modeling.
Yeah, and the research is published by Jan by way of NUS Med School, so that's available for everyone. What we are trying to do is to essentially combine all the relevant research that's out there and make it into something that's applicable to the layman, the average user, who just do not have the context to be able to make sense of any of this.
Yeah, so for this, what's the step between user? Who decides that's what the user should do?
So it's a layered model. At the base layer, you have clinical guidelines. So that's the minimum you need to be doing. If generally the government guidelines are a conservative way of saying what's the minimum test you need to be doing. If they say you need to do mammograms at 40, it's generally a good idea to do mammograms at 40 because it's been cost optimized. It's the thing that is widely recommended to everybody. So that's the base step. You at least need to be doing that. Now the question is beyond that, what can you do? Because those guidelines are pretty minimal. They talk about cholesterol. They talk about certain specific cancer screenings, blood pressure, weight. That's pretty much it. Now, after that, for each of the verticals, depending on what you're interested in, we will create models. So we'll create models for cardiovascular risk. We'll create models for metabolic risk, all the four horsemen, cancer risk. So the different models will work differently. Cancer models, you can actually draw a risk curve as to how often do you need to measure to get the cancer risk lower than 1%, for instance. Make it less than 1% chance that you will catch the cancer after stage 2. See, so this is math. You can actually do the math and calculate. Now, depending on your finances, how much you're willing to spend on it, you can, if you only spend more, you can get the probability of late detection much lower. So we'll ask you these questions. How much are you willing to spend? Are there anything that you're specifically worried about? If you have a family history of breast cancer, then that's the thing you should really pay attention to because your baseline risk is higher. If you have a family risk of cardiovascular disease, again, that gets weighted higher. So we'll use the user preferences. We will construct models for each of these horsemen, fit what the user preferences into the model, and that will be used to basically give us a risk score of each of the main things that could cause problems for you in the long run. And the ordering will be based on how much you're willing to spend and what your priority is. And all this is on top of the base recommendations from say WHO or the government.
So as a user, let's say I'm subscribed to your service. I say, okay, I want to spend 1,000 a year. And here's some basic tests I get offered, I guess, by the system. It tells me if you want to minimize the risk of your heart disease, you should test for, I don't know, Lp(a), ApoB, some maybe advanced inflammation markers. What do I do with those recommendations? Do I bring them to my doctor? How is that process? How do you envision that?
So in the long run, so this is basically a channel lead generation engine for all the screening companies, right? So in the long run, we would like to partner with screening companies or labs across the world and directly offer you packages that are suitable for you. Right now, you can only pick whatever gold, silver, platinum packages that are being offered on their website. Instead, we will construct a package, directly tie up with the labs and say, okay, here's the price for you for this package. That's the ultimate goal. I mean, that obviously requires us to have partnerships across the world. Right now, what we want to start off with is give you a recommendation, a list of tests. You go give it to your screening center, and then they will do the test for you. And you can go to any screening center you want. We can process any report as long as you send us a PDF or it syncs to Apple Health, and we will use your, if depending on your current, say, LP little a, your future cardiovascular risk might change, and obviously we'll change the recommendation as well based on the results that you upload.
So I did those tests which system recommended. I uploaded them back. So what's the next step? Does system offers me to do something about it?
So there are actually 3 actions for every state that the system is in. One is a test plan, which is, yes, so now right now you understand your current risk. So here it means, okay, something is really elevated, which means you should go see a doctor, right? You need clinical advice. The other possibility is there's something that's moderately high risk that you need to keep an eye on, which means that there might be something that you want to measure frequently or at a certain frequency, or there might be new tests that you might want to do to get more clarity on. Like, for example, if your breast ultrasound shows something, you might want to do a mammogram to basically confirm. So that will change the testing plan itself. But then ultimately we'll give you recommendations on other apps you can use. Those are solved problems. Like, we don't want to solve the problem of how do you eat less or reduce your weight, but we can tell you that, a lot of these tests are increasing your risk of heart disease. And here are some apps that you can actually use to reduce the risk of heart disease. And then as those apps send us back data, we'll update our risk. And then basically your risk of heart disease goes down over time. So if you look at the 5 pillars of longevity, it is eat well, sleep well, have low stress, exercise well, and finally you need to do tests to complete the feedback loop to understand where you're headed. So we're doing the 5th one, and we will recommend you the first 4 based on other solutions out in the market.
Well, I guess everyone knows the first 4.
and we see ourselves as a motivating factor to push you towards it, to kind of give you more clarity on these risks and bring the long-term risk to more immediate focus, so that you have the extra motivation to do what you probably know you should be doing anyways.
I'm trying to understand who is your sort of ideal customer.
I think so. Two things. The first one is, in terms of whom we're targeting, we try to focus more on the consumers, because there are a lot of disease management platforms out there, like for diabetes controlling. So that's very tight feedback loop between your results and your lifestyle, and the doctor is sometimes involved, sometimes not. And the reason why we're targeting the end users directly is because, let's assume that you have a budget of $1,000 per year, okay? And if there's so many functions in the body that you need to measure. Now, you can't measure everything with $1,000 budget. And if you have that constraint, then the way in which you have to look at it is over, say, a 5-year period. Now you have a $5,000 budget, right? And so we can allocate that based on which is the top risk for you today. And for a normal person to figure this out, it's super hard. And the doctors themselves don't think about it this way. And that's why if you go into a screening center or tell a doctor that you need to do a test, what's being offered is a national level low bar to you. So basically, policymakers have sat down years ago and said that, you are worth so much. And given that you're worth so much, we are willing to spend X dollars on you to subsidize you, or your insurance for that matter. And that is what you're getting. So if everyone goes and gets the low bar test, it doesn't mean that you are, completely risk-free. It just means that you have gotten the least amount of services that has the most amount of impact on the entire population. But that, is on an individual basis, your risk is still quite high if you don't measure the rest of the stuff. So our goal is to act as the resource allocator in that sense, where you get the best bang for the buck from a risk perspective.
In a way, we're preaching to the choir, because I've worked with medical devices, with EMRs. I've worked with another company which makes something similar to you. I know what all these markers mean, what longevity pillars are. I read all these books, listened to all these podcasts. So I'm 100% on board. But for somebody who is 90% on board, they might need to see,
The hard truth is that most doctors are the way they are today because they don't have the time to sit down and personalize it for everybody. And that's how the current system is just designed, right? And that's where we come in. And so we help the doctors do a lot of the heavy lifting of like asking all these deep questions and like, making sense of like their lifestyle, all of that. And then going through all the risk analysis and figuring out what needs to be done. At the end of the day, the doctor can then decide whether or not what we are suggesting makes sense. And they can give that advice to the users.
It's almost like in radiology, you can have a computer analyze your scan, find all the problematic areas, and then suggest to the doctor, do you want to look at that? Have you missed that?
Right.
Let's just double check, and it's like second pair of eyes. So probably in your case, it can be second, not pair, but 10 different eyes looking at the different angles. So my guess is one of the challenges is how do you prove that you're assessing that risk correctly and directing the people to the right tests?
Our mission is to help people understand what tests to do, when, and why. And the why part is super important for us. I think that's kind of missing in the market. So the why could be research shows across different populations that if you measure this, there's a correlation with other disease happening, right? So then you try it. The fact of the matter is it may or may not work for you specifically, but overall in the population it works. And this is how most medical decisions are done. But as Krish said, if you look at the entire population, the bar is very low. But for you, with a certain kind of risk, you might want to keep the bar a bit higher. And ultimately, it's prevention. You might do a test for 50 years and it might keep coming back negative, but that doesn't mean that it was not useful to do the test. It could have come back positive, and that's what.
You always play lottery. You want to keep an eye on it.
Exactly. So we will reference research papers. We'll reference data sets. We'll reference source on where we are getting this information, so that people can complete the loop on why is it you're telling me to do this test? Because if you look at the test plan that your health company gives, it just says chest X-ray. What are they looking for in the chest X-ray? Is that applicable to you? You don't know, but we'll tell you. Chest X-ray is to basically guard against the risk of this because you have a higher risk based on your other markers.
Yeah, I think, it should be transparent because again, probably the first people who will be willing to try a service most likely going to be like biohackers in nature who actually do spend some time reading studies and following all the latest research, so they will be sort of delighted to read anything that's applicable to specifically them, which can be in a way value in itself. If you have a digital system where you can unload your history and some test markers and it can tell you what's more relevant even without any testing, but it can highlight some things, almost like genetic reports you get and upload to like Promethean system. It tells you you should probably keep an eye on those conditions. It's not a guarantee, but just to be safe, are you using some large language models to do any predictions?
We use large language models mostly to help us make sense of research papers and data. Large language models are not very good at giving recommendations because the reasoning isn't very clear. So you want something more defined, like a rules engine. That's what we're building. So it'll basically be like, if you have this marker as positive, this research shows that. Basically, we look at it in terms of, let's say you have 3 markers, but you need a 4th marker to compute a risk score. Then you're like, okay, 4th marker is what you need. So we'll come up with rules like that. We'll consult with doctors. We'll consult with existing research. We'll take in data from existing recommendations, and we'll do the kind of mortality analysis from large data sets and feed that in as well. So we'll all be, I guess, AI, but more of statistical analysis and rules.
Yeah, it's more like assisted, computer-assisted diagnosis.
In the long run, we might have our own ML models as we get more and more data. We might develop them. They might prove to be useful. LLMs as well, they might prove to be useful as an interface. We don't know that yet. Yeah, for now, we're going to start with something concrete that's explainable and we can justify ourselves.
Yeah, because in a way, this way you can say exactly why you're recommending. You can always backtrack yourself to exactly a set of guidelines or research paper. Say we're doing this because of that. Do you have any doctors or clinical practices which can validate your recommendations?
Yeah, we're building out a board of advisory of doctors. The idea is that we will work with them to develop the rules engine for each of the horsemen first, and then the rest of the diseases that are preventable. But for the initial stage, it's going to be based on them reviewing the rules engine. And because it's a rules engine, we have control over the process, right?
Do you plan to recruit like 100 people and then validate them with a doctor, whatever recommendations you get? Have you been thinking about that?
So the plan that we have is to have every recommendation vetted by a doctor. So it's more of a sanity check. Different doctors might agree on and disagree on the nuances of a specific recommendation. What's important is it's in the right direction and it is explained properly as the reasoning behind it. So we'll have two levels of vetting. One is the rules themselves. We'll get a doctor specialist to look at each rule and make sure that makes sense. And then we will get the inputs and output of those rules as and when we recommend it to people and make sure at least for the first 1,000 people, and then you use the feedback to basically train the rules engine further and make sure it makes recommendations that make sense and the reasoning is correct.
Okay, so what I hear is that first 1,000 subscribers will get essentially free set of doctor eyes on their report. What else? All early supporters will get lifetime discount and you can cancel at any time. So yeah, that's pretty amazing. So when are you getting the first version out?
We're going to start disease specific. So we're going to launch the cardiovascular workflow rules engine first. And that's somewhere around the first quarter of next year. And then after that, we keep adding the rest of the disease profiles.
So do you have a doctor lined up who is going to double check the results? Let's say I am going to enroll today, put all my tests, which I have plenty, and get some recommendation.
Yep.
All right, that sounds good. And if you want to participate in the Medicine 3.0, all the links are in the description. And if you need to find a doctor who is going to work with that, I actually had exactly the same problem just a month ago, and that's why I interviewed Dr. Michael Kogan here, and there we cover how to find the best doctor for yourself. So check that video next. And as usual, living is smart, aging is bad, and I'll see you there shortly.